Good morning everyone. Today I'm going to present on flat anterior chamber, a unique case of viral keratitis, and we will discuss the role of oral steroid in case of viral keratitis. We'll go with the case presentation. Is 27-year-old male resident of Sirsa came to us with sudden diminution of vision, light sensitivity, pain and redness in the left eye since few days. There was a positive history of recurrence in the past. As the patient was very young, so we did the detailed systemic history. There was no significant history was there with the patient. So this was the picture of the right eye and left eye simultaneously. Right eye vision was 636. There was a diffuse nebulous scar with stromal edema, and left eye he was having hand movements. It was a perforated corneal ulcer. So we did the sampling of the left eye and it came negative, and he had a positive history of recurrence. So patient was diagnosed as a case of bilateral viral keratitis. So the right eye was diagnosed as stromal viral keratitis, and he was started on antiviral treatment. He was started on acyclovir 400 milligram 5 times a day. Topically in the right eye, he was started on lubricating drops, that is carboxymethyl cellulose 1% 6 times, and he was started on Predfort, that is prednisolone 1% eye drops 4 times a day in tapered doses. In the left eye, as he came to us, is a perforated corneal ulcer. So we have planned the eye for tissue adhesive bandage contact lens, and it was planned on the same day, and he undergone the same surgery. So as you can see in the picture, you can see the TA which is there, which is well opposed, and AC was well formed, and post-op BCL was in situ, and anterior was well formed. Patient was doing well on day 1 post-op. But after 6 days, patient was doing fine, and then suddenly he came with pain and sudden diminution of vision in the left eye. On examination, AC was flat and tissue adhesive was displaced, and IOP was distal low. We did the CDLs, which is a very simple exam to rule out whether there is a leakage or not. So it came positive. So we did the repeat TA BCL, and we now planned it with the Tenon's patch graft. So you can see that picture of the same displaced TA. We did the Tenon's patch graft with TA in the same eye, and patient did well, very well. You can see it is the day post-op picture on the next side. You can see there is an air bubble inside. AC was well formed, sutures were intact, and TA was on place. But then after some time, after days, 13 days, he again came to us with a flat AC and severe pain. This time the intraocular pressure was normal and CDLs was negative. We sent the patient for B scan, and just to rule out any kind of choroidal detachment, but which was within normal limit. So in case of very intense cyclitis or in case of iritis, sometimes patient behave like they don't make aqueous. In that case, maybe the reason it was having a flat AC. So we started the patient on oral steroids in view of intense inflammation, and luckily he responded well to the treatment. And these are the pictures after 10 months post-op. Right eye picture, you can see there was a patient best character visual acuity is coming to 612, and in the left eye he is maintaining a vision of 612 also. So coming to the HSV keratitis, you can see there are recurrent history of recurrent corneal diseases, recurrent history in the past. It can lead to corneal scarring, thinning, stromal opacity, neovascularization, in some cases blindness when it is not treated properly. So the take-home message in these cases that you have to ask the patient any kind of keratitis. You should always ask the history, whether there is any recurrence, what kind of trauma he went through, or is there any kind of organic body which has come in contact with the eye. So that is very important. Next thing is bilateral herpetitic keratitis is very rare, but we see, when I was doing my fellowship in Delhi under Dr. Sangwan, I have seen a lot of patients with bilateral herpetic keratitis. So you have to have a very proper examination and open-minded when you are seeing cases of bilateral keratitis. And intense inflammation sometimes can lead to flat anterior chamber. In that case, oral steroids did play a very good role. And if you have seen a repeated TA, displaced TA or flat AC, in that case, Tenor patch graft, good, very good, and along with oral steroids, should be considered in active intense viral keratitis. Thank you all. So, do you have guys any question you can ask me? So, yes, few of if you have a totally depends what the patient whether the patient is unilateral one eyed or is having like one eye is in safe. So the role of acyclovir is very limited if the patient is one eyed and he is having recurrent history of episodes in the past, and if you want to maintain the vision, so what happens when patient is having recurrent episodes, it leads to scarring. So what scarring does is deterioration of the vision. So if a one-eyed patient comes to you, so you have to see the patient, the profile, the recurrence, how many recurrence in the previous years, and accordingly you can keep the patient like what I do with my patients. Some of my patients are like kept once or twice a week. So so it's just like corona. It's a heat virus. Okay? So what happens? It comes again and again. So the patient just need a small amount of acyclovir. It can be in orally. It can be, you can start the patient. What I do is I just start the patient on ointment. So I tell the patient you just have to put small amount of ointment at bedtime. So that do really well in most of the cases, and I've seen many cases in which what happens, the patient stops when they get better, they just stop the putting acyclovir ointment. So we have seen a lot of cases with relapse. So in cases of viral keratitis, you have to counsel the patient properly that it will take a longer time. You have to put the drops or ointment for a longer time. You have to tell the patient that if you don't put the drops, it will have a recurrence, relapse, or that can lead to scarring, and that will lead to deterioration of vision. So this way you should tackle your viral keratitis patients. Any other queries? Thank you guys.